Hello everyone. This presentation unifies the core teaching points from about acute coronary syndrome. The goal is to move from recognition to reperfusion, then from stabilization to secondary prevention. I want you to leave with a simple mental model. First, identify where the patient sits on the acute coronary syndrome spectrum, then decide how urgently the artery must be opened, then apply the 2025 guidelines updates that improve safety and outcomes. Throughout the talk, I will highlight what is foundational, what is new, and what matters at the bedside for residents, hospitalists, emergency physicians, cardiology fellows, and all cardiology learners. Before diving into the workflow, it's worth seeing the major updates all at once. The 2025 guideline consolidates older STEMI and non-STEMI acute coronary syndrome guidelines into a single modern ACS document. The big clinical messages are these. DAPT therapy remains central. Tricaragor or Prasugrel are preferred over Plavix for most PCI patients. Radial access is favored. Complete revascularization is recommended in stable multivessel disease. Shock is handled differently with culprit only PCI upfront. Lipid lowering is more aggressive, and cardiac rehabilitation plus structured follow up are no longer afterthoughts. If you keep these themes in mind, the rest of the presentation becomes much easier to organize. Acute coronary syndrome begins with plaque disruption, either rupture or erosion, followed by platelet activation, thrombus formation, and downstream ischemia. It is helpful to teach ACS as a continuum rather than isolated labels. At one end is unstable angina, where ischemia occurs without measurable biomarker rise. In the middle is NSTEMI, where there is myocardial necrosis, but not the classical transmural ST elevation pattern. At the far end is STEMI, which usually reflects an abruptly occlusive process with transmural injury. Residents remember better when they connect the biology to the EKG and troponin findings instead of memorizing three separate definitions. We owe a lot to the giants on whose shoulders we stand. The trigger for acute coronary syndrome was determined by Dr. Erling Falk. He demonstrated that tearing of a thin inflamed fibrous cap exposes the necrotic core, instantly activating the coagulation cascade. Then Dr. Deward, his early angiograms, where he was performing them on patients who were having an acute heart attack, showed that 87% of the patients who presented in the first 4 hours had a thrombus. Therefore, it was determined that thrombus caused the heart attack, not that thrombus was a sequelae of the heart attack. You have to remember that time is myocardium. The first operational target is an EKG within 10 minutes of first medical contact. That means the emergency department, the clinic, and pre-hospital systems all need an organized process. The first EKG is non-diagnostic, but symptoms are ongoing. Repeat the EKG. Do not let a single normal tracing falsely reassure you in a patient with ongoing, evolving acute coronary syndrome. EMS notification, pre-hospital EKG transmission, early cath lab activation, all reduce total ischemic time. This is something that is very important to remember on the system side. Good ACS care depends on workflow discipline, not just pharmacology. Once the patient is in the hospital, High sensitivity troponin is a preferred biomarker because it improves both sensitivity and speed. In patients without a clear STEMI pattern, diagnosis should integrate serial EKGs, serial troponins, symptoms, hemodynamics, and clinical judgment. The modern approach is not simply to admit everyone with chest pain for a stress test. Instead, we use a clinical decision pathway that separates low risk, intermediate risk, and high risk patients. This helps avoid both missed acute coronary syndrome and unnecessary testing. Troponin alone should never be interpreted in isolation. It becomes meaningful only when interpreted in the context of the patient's story and the trajectory over time. Early medical therapy in ACS is built on rapid antithrombotic treatment. Aspirin is given upfront, then combined with a P2Y12 inhibitor. For PCI patients, tricalcigrol or prasugrel are generally preferred over clopidogrel unless patient-specific factors push you in a different direction. Anticoagulation, whether unfractionated heparin, enoxaparin, or biliverdin, depending on the context, help prevent thrombus propagation. Then come the therapies that stabilize the patient and improve long-term outcome. High-intensity statins, early beta blockers when not contraindicated, and ACE inhibitors or angiotensin receptor blocker therapy in the appropriate phenotype. It is important for us to think in layers: stop platelet activity, reduce clot extension, stabilize myocardium, and begin secondary prevention before discharging the patient. STEMI remains the clearest coronary emergency in clinical cardiology. Guiding principle is simple: open the artery fast. Primary PCI is preferred whenever feasible, with first medical contact or device targets of less than 90 minutes, driving systems planning. If PCI cannot be delivered within the appropriate time window, fibrinolysis remains an option. But this is not the endpoint. These patients who receive fibrinolytics still require early transfer and angiography as part of a pharmaco-invasive strategy. It is really an emergency bridge when PCI delay could be excessive. The practical bedside question is always, what is the fastest reliable path to reperfusion? This depends on the specific patient in the specific system, and this context should be remembered. And STEMI is not managed by reflexively taking every patient straight to the cath lab. Instead, timing is determined by risk, hemodynamic instability, refractory angina, electrical instability, or other very high-risk features push the patient into immediate invasive pathway. High-risk but stabilized patients typically require an early invasive strategy within 24 to 48 hours. Lower risk patients may undergo a more delayed invasive evaluation or additional non-invasive assessment depending on the clinical picture. Many NSTEMI patients absolutely need angiography, but not all need it in the next 20 minutes. Good judgment means matching the tempo of the intervention to the patient's risk profile. Once the patient reaches the cath lab, conversation switches from whether to revascularize to how to do it. Radial access is preferred to femoral because it lowers bleeding complications and is associated with better outcomes. In addition, intracoronary imaging with intravascular ultrasound or optical coherence tomography can improve lesion assessment, stent sizing, stent expansion, and apposition. This matters because suboptimal PCI has downstream clinical consequences. Technical choices inside the cath lab are guideline level decisions that affect reinfarction, bleeding, and recurrent ischemic events. In a stable acute coronary syndrome patient with multivessel disease, the guideline supports complete revascularization because it reduces later death and myocardial infarction. What we mean by stable acute coronary syndrome patient is that they're not in cardiogenic shock. When a patient is in cardiogenic shock, the strategy changes. Routine PCI of non-culprit arteries during the initial procedure is actually harmful. So the preferred approach for patients with cardiogenic shock is culprit-only PCI upfront. This explicit contrast should be remembered. In selected refractory shock patients, temporary mechanical circulatory support, such as microaxial flow pump or VA ECMO, may be considered. However, it should be remembered these devices are not benign. They may help, but they carry bleeding, ischemic, and vascular risks. As always, the right patient and the right timing always matter. The ACS admission is not complete when the chest pain resolves. Secondary prevention is part of acute care because the discharge plan determines long-term outcome. Most patients should continue dual antiplatelet therapy for approximately 12 months, though this must be individualized in the setting of bleeding risk, anticoagulation, or other competing concerns. Lipid management should be aggressive from the beginning with high intensity statin, and if LDL remains above the target, step up to treatment with ezetimibe, a PCSK9 inhibitor, or inclisiran. Cardiac rehabilitation is one of the highest value interventions that we underuse in patients. The real endpoint is not hospital discharge, it is fewer reinfarctions, better function, and lower mortality months later. The bottom line evidence for treating STEMI patients in this manner starts way back in 1988 with the ISIS-2 trial. Prior to this, care for coronary disease, particularly acute coronary syndrome, was fragmented with data from multiple small trials that was contradictory. ISIS-2 was the beginning of the mega trial era, a simple idea wherein randomization, blinded treatment could be tested statistically was established by ISIS-2. In this, the trial proved that aspirin plus streptokinase yielded a massive 42% reduction in mortality over placebo, and aspirin alone reduced one-third of the mortality. This was followed up in 1993 by the PAMI and Gusto 2B trials. These trials established PCI as superior to thrombolytics in reducing death and reinfarction. This continued with a STREAM trial in 2013 that validated the pharmaco-invasive strategy, showing early lytics with PCI within 17 hours yielded mortality rates under 6%. So we started off with acute coronary syndrome mortality in the 13% in the 80s and dropped it to less than 5% in the 2013s. I'm sure more progress is going to be made with time. Some unresolved areas remain, such as ideal duration of telemetry, best approach to some late presenters beyond 12 hours, and how we define the transition from acute to chronic coronary syndrome in a clinically meaningful way. Now, you should remember that guidelines are not infallible commandments. You should also recall that evidence evolves and that careful clinical reasoning still matters. In cardiology, confidence in your diagnosis is important, but so is intellectual honesty when the literature has not fully answered a practical question. I would like to close the talk by bringing everything back to simple, essential framework. Firstly, recognize acute coronary syndrome early, obtain the EKG fast. Second, decide where the patient sits on the spectrum, unstable angina, NSTEMI, or STEMI. Third, choose the right reperfusion or invasive strategy based on urgency and risk. Fourth, execute the procedure well in the cath lab, using radial access preferably and imaging when appropriate. Finally, treat discharge as a transition point into long-term prevention, not the end of care. If you master these steps, this sequence, you will not only perform better on examinations, but you will also manage real ACS patients with more safety and confidence. Thank you for watching. More to follow.